There's actually only one source that claims they can demonstrate abortion is 14 times safer than childbirth. It's an article published in the NCBI from pro-choice researchers Elizabeth Raymond and David Grimes that I will call the RG study for short. This article has become one of the most popular citations regarding safe abortion, and it's easy to read. It's only 5 pages, so I've posted the link in the description of this video. It's written by one of the biggest names in the pro-choice lobby, David Grimes, and it cites recognized sources like the CDC and Guttmacher Institute. Whenever people say abortion is 14 times safer than childbirth, they're referencing this study. This study might be the most famous and most widely cited paper on the subject, but despite its popularity, it's pretty much useless. Now, I know people on the internet exaggerate things, but I'm picking my words carefully here. The RG study has bad methodology, weak evidence. It's poorly researched, poorly argued, and doesn't even support its conclusion. There are 4 big problems with the RG study, and ERI speaking fellow John Farrar thoroughly dissects each problem in his article, which I have linked in the description. In this video, I'm only giving you a brief overview and simply presenting his ideas. The biggest problem for the RG study is they use critically different data sets that don't compare with each other. And unless you know what to look for, it might seem like they're comparing apples to apples. John gives this example to illustrate the point. Consider which is healthier, a dozen elementary school children or a dozen senior citizens. Before you answer, would it matter if the elementary children all had terminal cancer and the senior citizens were all part of an endurance running club? When 2 data sets are compared without controlling for variables, you end up with a faulty comparison. That's what's happening in the RG study. More specifically, the RG study compares the mortality rates for birth mothers and for abortion patients, but they didn't show the data sets are gathered and sorted in the same way. They can't show that because the data sets are radically different. That's why the primary source for the researchers' data, the CDC, was cited in the 2007 Gonzalez v. Planned Parenthood Supreme Court testimony. As the director of the Centers for Disease Control recently explained, the maternal mortality and abortion mortality measures are conceptually different and are used by the CDC for different health purposes. Problem number 2. The study compares data sets that differ in scope. This sounds similar to problem 1, but it's different. Not only are they comparing apples to oranges, but they're also comparing a complete data set for childbirth and related deaths with an incomplete data set for abortion numbers. You see, in the United States, we have voluntary reporting for abortion statistics, so the CDC data they are using to make their argument excludes Maryland, California, New Hampshire, Washington, D.C., and New York City. Those places haven't reported their abortion stats to the CDC in years, and because of their size and politics, they very well might have some of the highest abortion rates in the U.S. The Guttmacher Institute abortion data estimates that California alone accounts for about 15% of abortions. Cities and states aren't required to report abortions or abortion-related deaths to federal authorities. The 2 datasets RG compares differ dramatically. One covers everything meticulously, and the other is filled with only the whim of individual organizations. Any comparison of the 2 is meaningless. Problem number 3. The RG study uses inflation, false equivalence, and third variable fallacies to manipulate statistics. In discussions about the risks of childbirth, you'll hear people reference the maternal mortality rate. It's important to understand how this number is calculated when you're using it to make comparisons to abortion. The maternal mortality rate takes all birth-related deaths, the numerator, and divides them by only live births, the denominator. So all stillbirths and miscarriages are only addressed in the top number and not the bottom. The result is an inflated mortality rate for childbirth, but not abortion. If the RG study were trustworthy, it would avoid this inflation and also take care to exclude false positives, where pregnant women die of other causes unrelated to childbirth or abortion. The study is suspiciously careful to avoid these false positives for abortion cases, presumably because it would undermine its argument, but not so careful with childbirth cases. For example, if a woman has an abortion, contracts MRSA in the abortion facility, and subsequently dies, she would not be included in the RG study for abortion-related mortality data. But if the same woman instead delivered her child in a hospital, dies from complications of MRSA within 1 year of giving birth, the RG study would include her as a pregnancy-related death. This is a blatant double standard. Problem number 4. The RG study is not able to be reproduced by other scholars, so no one can corroborate the claim. One major test for serious scholarship in medical research journals is whether the conclusion is verifiable and repeatable. But the RG study fails here too. No other researchers have been able to verify the bloated claim that abortion is 14 times safer than childbirth. In fact, we find multiple studies point the other way. Abortion patients in Denmark, for example, show a higher mortality rate compared with birthing mothers in a 2012 study by Reardon and Coleman, and again in a subsequent study the same year. It's clear from these problems that the RG study isn't reliable. If we want to be able to compare the risks between abortion and childbirth, we need to demand consistent statistical reporting for abortion and intellectually honest scholarship. Reading John's article, linked in the description, is the best way to prepare yourself to respond to these claims about abortion being safer than childbirth. You should know these details for both yourself and the person you're speaking with.